Mechanism of blast injuries. Blast injuries occur as a result of explosions, which generate rapid pressure changes, thermal effects, and fragment dispersion. These injuries can be caused by various sources, such as improvised explosive devices, IEDs, industrial explosions, or military ordnance. Blast injuries are categorized into four types based on the mechanism of injury. 1. Primary blast injuries. Mechanism. Caused by the direct effect of blast overpressure on air-filled structures. The shock wave from the explosion creates sudden and extreme pressure changes, particularly affecting organs with gas interfaces, lungs, gastrointestinal tract, and middle ear. Common injuries. Lungs, pulmonary barotrauma, including alveolar rupture, pneumothorax and hemothorax. Gastrointestinal, intestinal perforation or hemorrhage. Ear, tympanic membrane rupture and a siccular chain disruption. 2. Secondary blast injuries. Mechanism, caused by projectiles and fragments propelled by the explosion. These fragments can be from the explosive device, environmental debris, or shrapnel. Common injuries. Penetrating trauma to the skin, eyes, or internal organs. Lacerations, puncture wounds, and fractures. Tertiary blast injuries. Mechanism, occur when individuals are thrown by the blast wind, causing blunt trauma. The victim may collide with stationary objects or the ground. Common injuries. Fractures, blunt trauma to the head, chest, or abdomen. Traumatic brain injuries, TBI. Quaternary blast injuries. Mechanism, result from other explosion-related factors not covered above, including burns from thermal effects, crush injuries due to structural collapse, toxic effects from inhalation of smoke, gases, or chemicals. Common injuries, severe burns, asphyxiation, or inhalational injuries. Crush syndrome with potential for renal failure. Management of blast injuries. The management of blast injuries involves initial stabilization, diagnosis, and targeted treatment. Each type of injury has specific management priorities. POPNAO. 1. Pre-hospital management. Assessment and stabilization. Use the ABCE approach: airway, breathing, circulation, disability, neurological status, and exposure. Stop external bleeding with pressure dressings or tourniquets. Administer high-flow oxygen for potential pulmonary injuries. Immobilize fractures and perform spinal precautions for suspected spinal injuries. Triage. Prioritize based on injury severity and resource availability. Emergency department management. Primary blast injuries. Pulmonary. Perform chest X-rays or CT scans for pneumothorax or hemothorax. Insert a chest tube for pneumothorax or tension pneumothorax. Provide mechanical ventilation with low tidal volumes for blast lung injury. Ear injuries. Assess for tympanic membrane rupture and manage symptoms, e.g. analgesics. Abdominal. Monitor for signs of perforation or internal bleeding with imaging, e.g. FAST or CT. Perform exploratory laparotomy if needed. Secondary blast injuries. Irrigate and debride wounds to reduce infection risk. Remove embedded shrapnel if accessible and causing harm. Administer tetanus prophylaxis and antibiotics for contaminated wounds. Tertiary blast injuries. Treat fractures with immobilization or surgical fixation. Manage traumatic brain injuries with neuroimaging and monitoring for increased intracranial pressure. Quaternary blast injuries. For burns, follow the rule of nines to estimate burn surface area and begin fluid resuscitation using the Parkland formula. For inhalational injuries, provide bronchodilators and possibly intubation. For crush syndrome, administer aggressive fluid resuscitation and monitor for hyperkalemia and acute kidney injury. Definitive management. Multidisciplinary care involving trauma surgeons, orthopedic specialists, ENT surgeons, and critical care teams. Ongoing management of complications such as infection, organ failure, and psychological effects, e.g., post-traumatic stress disorder. Key considerations. Blast lung injury is the most life-threatening primary blast injury and requires careful ventilation strategies. Early recognition and treatment of compartment syndrome can prevent limb loss. Psychological support is essential for long-term recovery due to the traumatic nature of blast events. Management